So, thank you. I know it's late in the day, but we'll try to keep you awake. So I'm going to speak about facial nerve reconstructive surgery. And we recently published this in this textbook. So you can take a photo, and this is the QR code for the website to purchase it. All of the material that I'm going to speak about today is in this book, in my chapter collaborated with a number of colleagues that you all know well. Also, I want to mention this course coming in July will be an excellent course, 5 days in the mountains in Serbia about medical neurotology, diagnostic testing by Professor Pavlovic is excellent in Belgrade. I will be participating. And also the European Skull-Based Congress, which Professor Szymanski and myself are contributing. And this should be excellent for not just neurotology or skull-based surgery, but there will be a whole track of educational courses for otolaryngologists in general, and especially for residents and trainees. So I really encourage everyone to try to come to these. So we heard a lot about the anatomy, different topics, examinations, so I won't go into great detail there, but this is the breakdown of the chapters in the textbook, okay? And this is following it exactly. I want to go first to the tumors. Let's go to the tumors, because in children, specific to children, now the chapter, though it is specifically for the pediatric otolaryngology audience, it includes a lot of cases in adults as well, because these are not huge numbers that we see, but the techniques are the same, whether it's a child or an adult. But I can tell you that my feeling is that I'm more likely to take care of a facial neuroma in a child as the cause of the facial nerve paralysis. Would you agree with that, Martin? Yeah, you know, because the other etiologies, for example, Bell's palsy, I have not operated or done a decompression for Bell's palsy in a child. It's very, very unusual because children just have a better regenerative potential. I don't know exactly why, but we tend not to see it. We do see Bell's palsy, but we tend not to see them require surgery. Almost all of the reconstructions that I'm doing in children are from some kind of neoplastic disorder. Okay? Even trauma, it's less likely to have a significant facial nerve paralysis traumatically in a child. Iatrogenically, yes, but child, they have a much more elastic skull and bone, so they're able to take a trauma much better. So it's a rare entity. But in children, this girl I operated on in Poland, I think almost 15 years ago. And she had a large facial neuroma. And what we did, this is the parotid, this was, we did a very large resection, including a middle cranial fossa. It was involving the descending portion, and it was going just up to the internal auditory canal. In this view here, you can see we did a single suture anastomosis to the nerve as it was going to the labyrinthine segment, and then we pulled it through the mastoid cavity, out of the middle cranial fossa. So here it's coming from the middle cranial fossa into the epitympanum and lying all the way out into the parotid. Okay? And here she is, this is about 10 years after surgery. So you can see she has very nice movement with this type of a very, very long sural nerve graft. So this brings up something that is specific also to children. They do very well with nerve grafting, better than adults. And the other thing is with very young children, I have quite a number of tumors. I usually can do a graft and then just wait. Sometimes they don't even need something for the eye until they regenerate, because the child has a lot of elasticity in their skin. You know, the youngest children have very, how shall I say, just, pudgy faces, and you almost can't even see that they have a paralysis when they're young, 3-4 years old. So the need to do adjunctive procedures like temporalis tendon transfers and lower lid and brow, these things are very, very uncommon to have to do in children. But there are a number of children that we have operated on with specific temporalis transfer techniques and other techniques that I will show you later. And those are the patients that have had a long-standing facial palsy, much more than 2 years, so that the graft no longer would be effective. So we have to remember that in adults or the whole general population, we usually consider about 1.5 years to be the limit, the duration of palsy, after which it is now questionable as to whether or not putting an interposition graft will take effect. And that is because with the long duration of palsy, the motor end plates and the neurons and the connection to the muscle degenerate. So even if you have a nerve which is able to regrow through the graft, you won't get reinnervation of the muscle. But in children, I would still do it, even a 12-7 or some kind of interposition graft, even up to 2 years, maybe even longer if it's in that range, because they have a better regenerative potential. And that's where doing some electrophysiologic testing to see if they have some fibrillation, if they have some motor end plate potential for reconstruction, and collaboration with neurologists is very important. So this is what we see with, this is a very long intradural to extradural to extratemporal interposition graft with excellent outcome because she was so young. This is another patient. This patient is, I believe, 17 at the time, and this patient I operated in Bydgoszcz, 2000, something like this, a long time ago. The plan for her was very interesting. She had a 6-centimeter acoustic neuroma, and Professor Mirzynski and I worked together for a number of years before we felt that it was reasonable to take the skull-based surgery in Poland at the time up to the next level, and we planned to do a translab on her with the neurosurgeon. It was all set. And it would have been the first translab that we did. And she, unfortunately, just the week before I was set to travel, plane tickets all reserved, she was admitted to the neurosurgical service with significant brainstem compression and central nervous system decline. So they put an extraventricular drain, and they called me. I said, look, it's impossible, I can't get there. Even if I leave now, it'll be 24 hours, and she wasn't in a stable condition. I said, listen, guys, do the best you can and forget about her facial nerve because she's going to die. So in this situation, facial nerve reconstruction is completely secondary to life. So they did some kind of a translab. We had practiced it in cadavers before, and they did something, and they also opened up above the temporal bone and did something through the middle fossa and cut the superior petrosal sinus, the tentorium, and they took out the whole tumor and saved her life, but also took the facial nerve, which was completely acceptable for this situation. It was emergency, more than 6-centimeter tumor. So I arrived, and she was stable, and here she is, She was young, healthy, and had complete transection, and we just did, in these days, I hadn't yet developed some of the techniques that we'll show you, and we did facial hypoglossal. And we did it entirely in the neck, identifying the facial nerve at the exit of the temporal bone and transecting it, and then connecting it as an interposition jump graft to the hypoglossal nerve. Why didn't I take the whole facial nerve out of the temporal bone and plug it in, which I have done for other cases? Why? Because she was a fresh post-op from a transtemporal approach, and to do that would be to completely open back up a CSF space. So we felt that to balance risk, we should just do it in the traditional, completely extratemporal approach. And if you look, this is about a year She actually has very good, this is the site of surgery, she's able to smile, and she has excellent, excellent symmetry at rest. So this is a completely acceptable result, and she's very happy. Without, again, very young patient, didn't need any transtemporal. She unfortunately, at the time, she had a spring, some kind of a Teflon spring put into the eye. We hadn't yet gotten gold weights. This was all, pretty new technology. This was more than 20 years ago, 25 years ago. And she did erode the Teflon spring through, and it scratched her cornea, and she had a corneal abrasion and was blind in that eye from a corneal abrasion. So it just underscores the importance of eye care. So the first thing you have to do when you have a patient with facial nerve paralysis is you have to get on top of the eye. You have to treat them with lubricants, lateral taping at night. If they get any redness or soreness, they must see an ophthalmologist early. And you can prevent a corneal abrasion, which is a devastating complication, just by a simple lateral tarsorrhaphy, just a suture in the corner of the eye to keep it closed temporarily. It's a very, very simple, easy thing to do, and should be done until some diagnosis and other things are organized. It's a very important point. So here she is. Let's take a look at how she's able to move. Okay. So I think, I don't have the sound, but Mirzwinski speaking to her and asking her to smile. You'll see, she'll be able to smile. And she even has a little bit of tone on the other side when she speaks. She's actually pretty good, even comparing to other reconstructive. If you didn't know, of course you see something in the mouth, but look, this is an excellent result, better than what we would expect from most adults. Okay, so this is all because of her young age. The advantage of dealing, so she's able to move it volitionally on command, right? So very nice result in children. Now, the next thing that we did years later, about 2010, I published a paper on reconstructing the facial nerve in patients that could not have any grafting. And this is a modification of another technique. Let's see if the publication, let me go. So I will find the publication reference later. But the first technique that was designed for temporalis transfer was to make an incision on the top and flip the temporalis muscle down. So you take the distal part and you flip it down and you connect it to the mouth. The next modification, which was done by another center, was to do what was called orthodromic, meaning that it moves in the same direction. So that involves making an incision in the scalp and connecting the temporalis tendon, removing it from the coronoid and connecting it to the face. And this patient, this is exactly what I did. And the reason I did it on this patient is I had first done his third operation for adenoid cystic carcinoma. So there was no facial nerve, there was already a substantial scar and incision, and all I had to do was extend it superiorly. So in this man, adult, it's very easy to just do it in the classic first modification, orthodromic. So let's see what he looked like before. We also did a gold weight. He didn't need a brow lift. He wasn't so asymmetric in his brow. And I also in him did a cable graft because there was a little piece of his marginal mandibular nerve just about out here, and I put a cable graft, so that actually helps a lot. And again, in children, they don't have beards, but having a beard in a man who has a facial nerve reconstruction is very useful. So here, this was his parotidectomy incision, so I staged it. I did it one day, we did the parotidectomy, and the reason we wanted to wait for margins. I did actually in him a lateral temporal bone resection as well. So, it's reasonable to wait for margins, because if you have to go back in and take more tumor, you don't want to disconnect your reconstruction. So I often stage these reconstructions, even if it could be done in the first stage. But so this, we remove it from the coronoid process of the mandible, and you actually cut out the zygomatic arch and just leave it out, because it allows the temporalis muscle to fill that space where you're missing the zygoma, and cosmetically it looks very good. And it also allows it to move freely in the trajectory of the soft tissue, and you get a much better result. So you basically, you make an incision in the face, and you connect this tendon. See, here's a zygoma, and this is very easy. And those of you who want to learn how to do this, it's actually a very good idea to do it like this first, because this is an open technique, and it's much more easy to see exactly what you're doing, and there's nothing wrong with doing an incision that's preauricular, extending into the hairline. It's completely acceptable, and as a matter of fact, this is the preferred technique to revise a minimally invasive technique that lost its connection. You can just open everything up and do it non-minimally invasive. So here I remove the zygoma, and then we pull the temporalis muscle through and connect it. Here's the temporalis muscle. Now here I used alloderms, which is an allograft dermis. You don't have to use an allograft. You can use a fasciolata. It's a very nice material available, but we were working with allografts at the time. This is 15 years ago, and alloderm works very, very nicely, but it's not necessary. And here he was before, and let's see, here he is after. Here, this is about a year after. See? And he has full volitional control of this that he's controlling with his temporalis muscle. And he's speaking, you see, he doesn't move when they speak. That's typical. You're never really going to get anything that's going to look symmetrical with speech. So you train the patients to speak with a more subtle expression, even to smile. You know, some people smile like this. You know, you tell them, no, practice in the mirror and just smile with a simple smile. You know, a nice smile, and keep it symmetric. So it's very, very nice. Here he is. This is even, I think, about 2-3 years later. I saw him back. So it holds up very nicely, and you can do a very secure connection. He also had a gold weight put in, and he's helped by getting a little bit of tone here by the marginal mandibular nerve. So if I have to choose one division, if there's not too many divisions available, to put a graft, I will put it to the marginal mandibular nerve to put a cable graft if I can only choose one branch, because getting that extra bit of tone and counter traction to the movement of the other side is very useful. It's much more effective than grafting to the middle section, because you're already compensating for that with the temporalis, and it's much more effective. The gold weight is extremely effective with the eye closure. So really the only place that can benefit from a graft, if you only have to choose one, is to put it in the lower division, right? This is the article. Look it up. It's myself and my partner, facial plastic surgeon, Dr. Seidel. It's American Academy of Otolaryngology, 2011, okay? This girl was the first patient we did in the minimally invasive, and she has NF2. She was operated on at the House Ear Institute, very famous center in California. She was operated on 6 years before she saw me, and she had a complete facial nerve paralysis, and she was left like this for 6 years. I don't know why. Maybe it was, who knows the reason, but it's kind of a shame. You know, I was kind of surprised. But there are many patients, unfortunately, that are walking around like this, you know. And she was completely bilaterally deaf. The other tumor was just being observed. It was relatively small. And here's her before and her after. And I'll show you. She also has this nasal neurofibroma. So I'll show her what we did. This day, we actually planned to do it in this standard first modification orthodromic. And we looked at her, and I had recently spoken to one of my colleagues, an oral maxillofacial surgeon that I collaborate with in India, and we were just discussing for some other case this coronoid process and the importance of it. And he said to me, you know, the coronoid process is completely unimportant. You know, you can completely detach the coronoid. And we just had this conversation, and it stuck in my mind. And we showed up to do this operation, me and Dr. Seidel. I said, wait a second, let's think for a second. Why do we have to make this incision up in the scalp? Let's see if we can do the whole thing through the facial incision. Instead of taking the temporalis muscle off of the coronoid would be very difficult in this hole. But I said, we don't have to take it off. We can just cut the coronoid off. It's very simple. And then we'll have the coronoid, and we'll use the coronoid as a handle. And that's exactly what we did. So here, I just grabbed the coronoid, and I'll show you, I have a little film of it. And then at that time, I drilled a hole in the middle to anchor it. But now, I actually don't drill the hole because I'm afraid that over time, if I use the hole to anchor the fascia, it may, over time, just erode. Maybe the hole will die. So I fasten it around it. So here is a video. I've used an endoscope. We don't use an endoscope for the technique, but I just used an endoscope to show, to demonstrate exactly what we did that day. So you can see I'm moving her jaw, and you can see this is her temporalis. It's moving right there. Here's the coronoid and the tendon. It's all connected. This is in the buccal space. And you just want to open this up bluntly because you don't want to cut the parotid duct. But if you just use your fingers and dissect this, look here, I put a reciprocating saw, and I didn't film it because it just covered up the lens with the bone. So we just cut it, and now here it is. So I have a coker on it, and I'm holding the coronoid process. So now this, you want to back dissect it. Here it's been cut. So you know, usually when you're doing this, and especially in children, this is a very small space. A lot of this you have to do by feel. That's why it's a good idea to do the open technique first and see what the anatomy is. Here I drilled a little hole in it. Again, like I said, I don't do this anymore. I just suture around it. And now, Marcin and I were working on using an orthopedic tendon suture system, so to try to improve it, to make it even easier. And it seems to be working nicely. This is another patient. You see, you take this fascia lata and you make a little incision here, you pull it through just to create a stability of the lip. So the lip, when they speak, on the contralateral side, this adds some stability so the whole lip doesn't pull. All right, so you stabilize the lip in a central fashion. I allow this to be central, and I tack a suture here, and then I make a connection of the second tendon. See, there's two, the tendon is one long tendon. You need about 8 to 12 centimeters of fascia lata. Here now I just connect it to the bone itself, and you measure it, and you want to overcorrect. You want to see, at minimum, you want to see the first premolar. And this is the kind of effect. Here's another patient who was in our study. Here's what he looks like. And when I look at this film, to be honest, I can't remember whether I corrected the left or the right side. I think it was the right side. Let's see, was it? Yeah, it was the right side. Here's another patient. Now this, let's see, what time is it? Okay, we're a little long, so I will skip this. This is also facial neuroma in adult. We did both. We did the nerve graft, and then we did here he is after the nerve, and we also did the reconstruction and a gold weight. And here's what he looks like after 8 years. He actually can whistle. I didn't make the incision like I do now. You know, at that point, I was just making the smallest incision, you know, going through this minimally invasive. It's a mistake. Now, I make an incision that exactly parallels cosmetically the crease on the other side. I offered him to take him back to the operating room just to make an incision and suture it back, but he doesn't want to. He's okay. Now, let me show you the last one. This guy I operated on in Serbia. He had a very large facial neuroma, same operation. I went through transtemporal. He was already deaf. I did the graft. And here, I did the operation, minimally invasive, about 2-3 months later. So if they have a craniotomy, I will do that. I will put the graft in because you don't want to pull on the graft, you know, immediately in the postoperative period. So you wait about 2 to 3 months until they're completely healed, for the graft and all of those factors. And look how he looks post-op. He looks, you know, all swollen. He looks awful because we really stretched his cheek. Now here he is. This is a year later. He's at the beach in Montenegro. And he has a combination of a nerve graft, which is giving him some movement, and the minimally invasive temporalis transfer and a gold weight. And I also did a brow lift on him. And then here he is again. He's about 6 months later. Let's see.
And here is the the most recent one.
Here is a lady that I did with March, and she had a parotid cancer, correct? Yes, so here she is before.
Dobrze, otworzyć. Uśmiechnąć się. Zęby wyszczerzyć, proszę. Dobrze. I spojrzeć w górę, zmarszczyć czoło, tak proszę. Dobrze. I jeszcze raz na aparat proszę patrzeć.
But here, this is her a week post-op. So I want to show you this because you see, she's hyper-corrected because they always come down about almost 50% of the original correction, it stretches. And she's had a brow lift, it's hyper-corrected as well, and she had a gold weight, and it also doesn't close fully. But that's because in 3 to 6 months, her brow lift is going to droop, her eye's going to close completely, and this is going to be centralized. Okay, so you want to overcorrect, and then they can end up with a very nice result.
Proszę zamknąć oczy. Dobrze. Otworzyć oczy. Uśmiechnąć się. Dobrze. Dziękuję.
And you want to counsel them to that, that you're going to overcorrect them and they're going to look funny for a while in order for them to be perfect. Right? Okay, thank you very much.